Good morning, everyone. Sorry for the delay. We're just working through some technical things. It's my pleasure this morning to introduce our Grand Rounds introducer. Okay, and so our Grand Round speaker Dr. Moldoveanu will be actually talking about non-invasive respiratory support and acute respiratory failure. But to give him the proper introduction, I'm actually going to introduce Dr. Rodrigo Cavalazzi, and as you probably heard, I guess one of the best teachers we've ever had in any discipline at University of Louisville. He currently does general pulmonary and critical care, and his career has been going northward ever since being in southern Brazil in Santa Catarina, and moving up to Sao Paulo, and then more north, University of Miami for residency, and then to Thomas Jefferson for pulmonary fellowship. And he's currently associate professor and director of the medical intensive care unit at UofL Hospital. And with that, thank you very much for introducing our speaker, Dr. Cavalazzi.
Thank you for the kind words. It's also an honor to introduce Dr. Moldoveanu. His lecture entitled Non-Invasive Respiratory Support in Acute Respiratory Failure. Dr. Moldoveanu graduated in medicine at University of Louisville in 2000. He completed internal medicine residency in 2003 at Indiana University, and his fellowship in pulmonary and critical care in 2006 at University of Louisville. He started as an assistant professor at University of Louisville in 2006. He stayed there until 2012. He went into private practice, and luckily he joined us back as a faculty member in 2018. He has obtained board certification in internal medicine, pulmonary, critical care, and sleep disorders. He's very esteemed by our fellows. He obtained Faculty of the Year award twice, including last year. He is very active. He's director of the sleep lab, both at the VA and Shelbyville Hospital. He has clinics at the VA, University of Louisville, and satellite hospitals. He's very active with teaching and patient care. He does a sleep clinic, general pulmonary clinic. He does ICU, and he has several publications in the topics of sleep and respiratory physiology. With that, I'll pass the word to Dr. Moldoveanu. Thank you.
Thank you very much. Let me share screen. Let me see. Can you guys see my screen?
Not just yet. Okay.
Do you see my slides?
Yes, there we go.
Okay.
Perfect. All set.
All right. So we're going to talk
go.
really quickly about non-invasive respiratory support and acute respiratory failure. Our goals for this topic, let me see if I can get it to work, is to discuss methods of non-invasive treatment of respiratory failure, discuss indications for non-invasive treatment of respiratory failure, and discuss the limitations for non-invasive treatment of respiratory failure. So starting in 1952, following a polio epidemic in Copenhagen, they discovered that tracheostomy plus positive pressure ventilation can decrease the mortality in acute respiratory failure by more than 1/2. And starting in the 60s, we had the observation of improved mortality in acute respiratory failure with positive end expiratory pressure, or PEEP. And from then, in the 1980s to the 2020s, we've had significant improvements in minimizing the side effects of mechanical ventilation. Now, the complications of invasive ventilation have to do with the PEEP, which is the ventilator-induced lung injuries, but there's also several other complications, such as the complications of endotracheal intubations, and most significantly, the complication of ventilator-associated pneumonia. Also, the complication of excessive sedation needed to keep the patient intubated, the need for restraints, the need for central lines, the need for urinary catheters. So a lot of complications in the ICU, from CAUTIs to bed sores, are associated with prolonged intubation. So starting in the 1940s, there's been an interest in non-invasive ventilation as an alternative. It was first studied by anesthesiologists at Bellevue Hospital in the 1940s, but as invasive ventilation became the thing, the NIV took a back seat for extended term ventilation, although respiratory therapists continued to use it for intermittent treatment, IPPB, where they would put patients on positive pressure ventilation multiple times a day for a few minutes on the wards. What really started the respiratory failure improvement increase was in the introduction of sleep apnea treatment with CPAP in 1981. And since then, we've had significant improvement in patient interfaces and masks. And in 1980-89, Maduri reported successful use of NIV to prevent intubation. And the number of studies since the mid-90s on NIV and acute respiratory failure has increased dramatically. Another thing that improved in the 90s was the improvement of ventilators and their ability to compensate for air leak, because obviously the interface on non-invasive ventilation, that's one of your major issues, is the air leak. So respiratory failure basically has two components. That's the ventilatory dysfunction, which is the sensation of dyspnea, the increased work of breathing, the increased use of accessory muscles, and the hypercapnic respiratory failure. And these are all treated with ventilatory support. The other part is the hypoxemia, which leads to hypoxic respiratory failure, which is basically, as we all learned, treated only by increasing the fraction of FiO2 and increasing positive pressure, which increases the size of the diffusion membrane of the lung. There are basically three main methods of non-invasive treatment, and we're going to review that very quickly. One of the biggest improvements in the past several years has been the high-flow nasal cannula. The issue with even something like a non-rebreather or standard oxygen is that it's only able to generate about 15-20 liters a minute flow. So the development of high gas flow rates with an adjustable fraction of oxygen minimizes dilution by ambient air, and it decreases the dead space because it washes it out with fresh oxygen, so that decreases the work of breathing. You also have a modest PEEP generation, which is determined by the airway anatomy. There is increased expiratory resistance, leading to a prolonged expiratory phase, which can help in things like COPD exacerbations, where you want a prolonged expiratory phase, and the humidified gas may assist with the clearance of secretions, which has been a problem with NIV without humidification. We have CPAP, which is continuous positive airway pressure, which has several indirect benefits. It does not directly affect ventilation, but it assists in various ways. It counterbalances the mechanical load of residual and expiratory alveolar pressure, also known as auto PEEP, which, especially in COPDers, is a significant increase to the work of breathing. It combats atelectasis and may facilitate alveolar recruitment, and provides a mechanical stent to the upper airways. Many of our patients have collapsible upper airways, which do not help when they are in respiratory distress and are making significant negative intrathoracic pressure when they're taking a deep breath. They also, in patients with obesity who tend to have easily collapsible airways overcome the critical opening pressure of those collapsible airways. And importantly, it decreases the cardiac preload and afterload by compressing the IVC. It can improve cardiogenic pulmonary edema. Non-invasive is mask ventilation with PEEP. The benefit to it is that the inspiratory pressure directly increases the tidal volume and has a substantial reduction in the work of breathing. And I always tell, and I don't remember exactly what reference I got this from, that the work of breathing during quiet respirations takes up approximately 10% of the delivered oxygen O2 that is sent out by the heart to the entire body. However, in respiratory distress, you can have in excess of 55% of the total use of oxygen by the body being used by the respiratory muscles. So by reducing the work of breathing, you significantly reduce the oxygen consumption and improve the gas exchange. All right, so these are the three main ways of increasing effectiveness of positive pressure delivery. We talked about the high flow nasal cannula. We talked about the face mask. And one of the things that is gaining prominence is helmet ventilation, where you are able to deliver PEEP with using a helmet that fits over the head and has straps under the arms. Now, let's talk about kind of the benefits. The benefits of the high flow nasal cannula is practically spontaneous breathing, patient comfort, able to take nutrition, as we said, the mobilization of secretion, and the patient is able to communicate with caregivers. Sometimes you get patient intolerance of the high flow, especially through congested nasal passages, but that's not that much of a problem. It can be used for pre-oxygenation before intubation, can be used for proning, and is easily applied to remove. In fact, we use it in combination with more traditional non-invasive ventilation back and forth. There is a potential risk for patient self-inflicted lung injury, and we'll talk a little bit about that later. The benefit for an institution is that lower flows, it can ostensibly be managed outside of an ICU in a step-down unit with close monitoring. One of the downsides for the facility is that having many of these may severely tax the oxygen supply of the facility. The face mask non-invasive ventilation is the one that we're most comfortable with and consistent with. It can be a temporizing device while awaiting treatment for certain rapidly reversible conditions. The downsides are that with prolonged use, you can have significant skin breakdown and ulcerations of the face with the oronasal device. There is decreased secretion clearance. Nutrition is challenging, and we've all had that issue where you're trying to do non-invasive ventilation with a nasogastric tube in place. There is the concern for nausea and vomiting and the possibility of aspiration. So therefore, any evidence of that or encephalopathy confusion are contraindications, since the patient is supposed to be spontaneously ventilating. It can be easily applied and removed, and you can even use it with proning, although I've never done that. There's difficulty using it for transport to CTs. There's difficulty with procedures such as bronchoscopy or CT imaging, and there's the potential for self-inflicted and ventilator-inflicted lung injury. The limitation is that it is ideally delivered in a closely monitored setting where risk of progressive respiratory failure can be rapidly identified. And the helmet non-invasive ventilation, the patient can take nutrition through ports in the helmet. There is greater tolerance and less claustrophobia than with the face mask. There is complications of the upper limb edema from the straps going under the arm, and the potential risk for upper limb venous thromboembolism. There's better tolerance than for the face mask, and you need to take less breaks. There's, again, difficulty with transporting, again, difficulty with bronchoscopy and accessing it for some difficulty with accessing for oronasal facial care. Time to intubation is longer than with other methods, and these patients are more challenging to prone. The limitations for a facility is that the healthcare team learning curve is a little higher. It is, again, ideally delivered in a closely monitored setting where risk of failure can be very rapidly identified. Let's talk about a couple of indications and a little bit of clinical evidence of for acute for non-invasive ventilation, including acute hypoxemic respiratory failure, cardiac pulmonary edema, COPD exacerbation with hypercapnia, post-extubation, and post-operative respiratory failure. The major issue is with acute hypoxemic respiratory failure, including ARDS, is that you have a combination of lung atelectasis, you have the permeability pulmonary edema, and you have three major issues. You have decreased oxygenation, you have impaired ability to ventilate, and because the extrathoracic muscles are trying to basically move a wet sponge around, you have significantly impaired respiratory mechanics. And this is traditionally treated with invasive mechanical ventilation, requiring intubation and heavy sedation with all the problems that we have with a prolonged immobility, ICU myopathy, multiple possibilities for infection in the ICU. So non-invasive ventilatory support maintains wakefulness, maintains spontaneous breathing, it augments ventilation and the oxygenation, and the non-invasive pressure supports prevents diaphragmatic failure. We have had quite a bit of experience during the COVID pandemic with patients being temporized with non-invasive ventilation. But non-invasive ventilation can have significant harmful effects. And a few of the limitations, as we said, the significant air leaks around the interface decrease the effective ventilation. Also, the air leaks prevent more than a rather modest level of PEEP being delivered. And then there's the other thing, skin breakdown at the interface, difficulty giving the patient feeds if the patient needs to be on non-invasive ventilation for a prolonged period of time. The major sticking point and theme of this talk is that the problem is that non-invasive ventilation can cause a delay in intubation for worsening respiratory status. And we have the tendency to leave patients on non-invasive ventilation a little bit too long. Other things is the presence of non-pulmonary brain dysfunction, the presence of shock, the presence of encephalopathy, the other organ dysfunction may require intubation to protect the airway and reduce O2 consumption. That's a very important point in deciding what patients to put on non-invasive ventilation. There was for a long time, there was a thought that severely immunocompromised patients, such as bone marrow transplant patients, should not receive invasive ventilation. And that was due to a very high rate of endotracheal tube related infections. And that was a major problem in the 90s and 80s. And however, in the past 30 to 40 years, improvements in non-invasive ventilation have made it so that's no longer an issue. The immunocompromised patient should be treated exactly like the immunocompetent patient. Those that are appropriate for non-invasive ventilation are appropriate, and those that are not should go ahead and be intubated. The other issue is that the patient self-inflicted lung injury, which is similar to VILI, and let's talk about that for just a second. Dr. Cavalazzi has done a wonderful talk on ventilation in ARDS, and I'm cribbing some of his stuff here. Lung injury is proportional to the strain of the lung. The pressure producing the strain distending the lung is the transpulmonary pressure. It's the difference between airway pressure and the pleural pressure. The experimental exposure to vigorous spontaneous breathing, and this was shown in rat models, can be associated with significant lung injury by causing lung overdistension. So it does not matter if the lung overdistension is done by positive pressure ventilation or by negative pressure ventilation. The injury is the same. And since the non-invasive ventilation is not usually limited by, or so let me say, it's not quite as easy to control tidal volumes on non-invasive ventilation. It can actually assist with overdistension and help precipitate worsening respiratory failure. The key to remember is that large tidal volumes and are strong predictors of NIV failure, and that the patient needs to be intubated. And here's a little picture that I stole from New England Journal of Medicine 2013, showing that the patient at marked respiratory stress has a high transpulmonary pressure, even though the alveolar pressure is negative. The large negative swings in pleural pressure can damage the lung. Also, there is an effect where the dependent portions of the lung are having rapid opening and closing of the alveoli, which leads to atelectatrauma as well, and can lead to worsening hypoxia. So just to remind myself, acute hypoxemic respiratory failure is considered mild when the PaO2 FiO2 ratio is 200 to 300. 400 is around normal. Moderate is 100 to 200, and severe is less than 100. there have been several studies and meta-analyses of the studies that show that the risk of intubation is lower in patients with high flow nasal cannula or non-invasive ventilation versus conventional O2. However, the early studies showed no consistent effect on mortality. In 2015, a multi-center open label trial comparing high flow nasal cannula, NIV, or standard O2 showed an improved 90-day mortality with high flow nasal cannula. A 2020 meta network analysis, 25 studies. This was the big one, comparing all methods of NIV showed lower mortality for face mask and helmet NIV, and all three of them methods decreased intubation risk. Interestingly, a small single center patients with helmet versus face mask showed significant lower 90-day mortality and risk of intubation with helmet versus face mask non-invasive ventilation. And this was quite small study, but probably a larger study needs to confirm these findings. However, the one study that I really want to talk about is the lung safe study, published in 2016. It had 2,013 patients with ARDS, and 15% were managed with NIV, irrespective of the severity of hypoxemia. And NIV was found to be associated with higher ICU mortality in patients in the severe hypoxemic respiratory failure, the PaO2, FiO2 less than 150. And again, this underlines the need for careful patient selection when considering NIV use in ARDS. So the takeaway in acute hypoxic respiratory failure is that non-invasive respiratory support devices potentially decrease the risk of intubation and should strongly be considered in patients with mild, moderate hypoxemia, not severe hypoxemia, in absence of significant organ failure, such as encephalopathy, or in shock. For severe hypoxemia, the evidence is significantly less supportive. Let's talk a little bit about cardiogenic pulmonary edema. So we talked about that both CPAP and non-invasive ventilation decrease the work of breathing, increase the functional residual capacity of the lung, and improve mostly through the heart function. They decrease preload and they decrease afterload, improving the cardiac output. It is now standard of care to use it as a bridging therapy during hypoxemia and respiratory distress while the urgent medical therapies are administered for cardiogenic pulmonary edema: loop diuretics, morphine, nitrate, oxygen, and positioning. If the patient is in shock, like for acute hypoxic respiratory failure, NIV is not recommended, and is also not recommended for acute myocardial ischemia in a patient that needs to be revascularized, as we're not consistently able to deliver the levels of FiO2 that are needed. Meta-analysis of CPAP and NIV showed that there was prevention of intubation in cardiogenic pulmonary edema. There was decreased hospital mortality. The greatest benefit was in patients with acute cardiogenic pulmonary edema plus hypercapnic respiratory failure. And the patient's respiratory distress often improves a lot sooner with NIV compared to plain old CPAP. For COPD exacerbation and hypercapnic respiratory failure, the benefits are offloading respiratory muscles, counteracting the dynamic hyperinflation, the auto PEEP, which occurs due to the prolonged expiratory time that occurs in COPD exacerbation. And it is, again, a bridging therapy for these patients while administering meds, which are the definitive therapy. Steroids, bronchodilators, antibiotics. The randomized control trials shows that it prevents intubation in approximately 65%, and it lowers mortality in patients with COPD and hypercapnic respiratory failure in the same meta-analyses by 50%. So NIV is considered first-line therapy. It is the mode of choice. There are other modes such as CPAP or pressure support ventilation. However, those are less likely to improve alveolar ventilation, and the bi-level NIV is the mode of choice. The high-flow nasal cannula has been studied in COPD exacerbations, and there is insufficient evidence to support its recommendation. It is also effective in patients with obesity hypoventilation syndrome and hypercapnic respiratory acidosis, who may benefit both from the PEEP and from the driving pressure to drive down the hypercapnia. In non-hypercapnic respiratory failure due to COPD, there were several small prospective trials which showed no impact on mortality and relatively poor tolerance of NIV. So the ATS recommendation is not to use NIV. However, this is done on a patient-by-patient clinical impression basis, but it should not empirically be used. And there was a pioneer study by Manchebo in New England Journal, 1995. If you want to look that up, it's a very good read. Okay, since it's first-line therapy for COPD, what about asthma? So there was the evidence is positive, but not quite as strong as for COPD. In this multi-center retrospective cohort study in the United States, the use of NIV was associated with lower odds of receiving invasive ventilation and in-hospital mortality. The sticking points has been that patients with asthma exacerbation who had pneumonia as well did not do as well with non-invasive ventilation. And obviously things like severe sepsis and acute renal failure are not good indications for the use of NIV. There was improved outcome, but it should be very cautiously used in patients with comorbid conditions. After extubation in the ICU, a lot of patients within the first 7 days, approximately 10 to 20% will need to have be re-intubated. NIV or high-flow nasal cannula after extubation has been successful in preventing re-intubation in high-risk patients, especially patients with COPD, heart failure, and obesity. And a trial in 2019 showed that a combination of NIV and high-flow nasal cannula is better than high-flow nasal cannula alone to prevent reintubation. The sticking point is that we have tried NIV as a rescue maneuver in post-extubation respiratory failure. However, during several trials, its use as a rescue maneuver has been independent factors associated with increased mortality. And this is likely due to a delayed reintubation. This is probably not applicable to patients who had respiratory failure from COPD exacerbations or pulmonary edema, but very close monitoring is needed. In general, NIV as a rescue maneuver has not been very helpful. And in post-op respiratory failure, we've shown somewhat mixed results. There was a positive study which showed preventative use of high-flow nasal cannula in patients that are obese or at high risk prevents reintubation. And a study on post-op CPAP and NIV showed that they are effective in decreasing the incidence of reintubation following abdominal surgery, which is the one that's been most studied. However, there was a large trial in Lancet, and this one I think came from Italy, where the routine use of prophylactic CPAP following abdominal surgery after elective abdominal surgery did not reduce the incidence of pneumonia, intubation, or death. This was CPAP, not NIV. However, our takeaway from that is that CPAP should not be used necessarily empirically in patients with major surgery. Okay, a few practical considerations. Which methods to use? So the face mask NIV is recommended for COPD, obesity, hyperventilation, or cardiogenic pulmonary edema. Consider a trial of high-flow nasal cannula or NIV for acute hypoxemic respiratory failure in mild or moderate hypoxemia. However, if you have severe hypoxemia, shock, AKI, altered mental status, encephalopathy, consider earlier intubation. Risk factors associated with failure. NIV failure has been documented as an independent risk factor for death in ICU patients. Especially in the patients that seem to be identified are the ones that have large intrathoracic pressure swings, that are taking large tidal volumes and have very increased work of breathing. And so there have been several studies to look at prediction of failure with NIV, but the best ones are the PaO2 FiO2 ratio continuing to deteriorate or being less than 150 millimeters of mercury 1 hour after initiation of face mask NIV, and high tidal volumes greater than 9 milliliters per kilogram are strong predictions of need for reintubation with patients. As a kind of a general goal is, if you place the patient on non-invasive ventilation, you should check back on them, see if there has been significant improvement in a time frame of about an hour to 2 hours, not much longer than that. Thank you very much. This was my main reference for this lecture from New England Journal 2022. And here are a few additional references. Thank you very much. Do y'all have any questions?
That was a spectacular review. Dr. Cavalazzi, you want to run the post-match interview?
Yeah, thank you very much for the lecture. That was great. Bobby, during the COVID pandemic, many patients were treated with non-invasive ventilation, high-flow nasal cannula. One of the concerns with non-invasive ventilation is that it can also cause ventilation-induced lung injury
Yes.
because the transpulmonar pressure, which is what is responsible for ventilation-induced lung injuries, the pressure in the lung, it's equal to the plateau pressure, which is the pressure to overcome the recoil of the respiratory system, minus the pleural pressure. The pleural pressure can be very negative when you're spontaneously breathing. So there has been concern about the development of ventilation-induced lung injury in patients who are being treated with non-invasive ventilation. They have full-blown respiratory failure. For instance, we know that marathon runners can develop pulmonary edema. We know that horses, sometimes they have lung bleeding after a horse race. So what is your take on that? Is this something that we need to be concerned? Ventilation-induced lung injury in someone who is being ventilated with non-invasive ventilation?
Yeah, yes. We do need to be concerned about it. And that may be one of the reasons why the high flow nasal cannula, which delivers less tidal volumes and may have a bit of a edge on traditional non-invasive ventilation in certain populations. The other thing is that, as we said, with the non-invasive ventilation, you cannot control the tidal volumes as well. You cannot control the how high the intrapleural pressure occurs. So my thought is going back to if the patient appears to be struggling, if you do not see a decrease, if you place the patient on non-invasive ventilation, and you see that the patient has high tidal volumes, high respiratory rate, or a deteriorating PaO2 FiO2 ratio, then it's time to call it a day and place the patient on invasive ventilation. And on invasive ventilation, you can sedate the patient to allow better synchrony with the ventilator and reduce these large swings of interthoracic pressure. It's a more controlled environment. So I think that at least I think I've been more guilty than many other people, is of leaving patients on non-invasive ventilation too long as they're deteriorating, and having poor outcomes. Also, once the patient has become more severely hypoxic, then the intubation is fraught with more peril, as the patient has less physiologic reserve to tolerate the procedure.
Thank you. That was a great explanation. So I also like that you mentioned that once you put a patient on non-invasive ventilation, it's very important to reassess 1 hour later. I think sometimes this is overlooked. Patients are placed on non-invasive ventilation, and 6 hours later, someone goes check on the patient, and the patient is in frank respiratory failure requiring intubation. So the idea that once you start non-invasive ventilation, you have to reassess the patient 1 hour later. This is a very important concept, checking the patient clinically with blood gas. You know, I was very impressed. I'm always impressed by the data supporting non-invasive ventilation in patient hypercapnic respiratory failure and COPD. You mentioned that it decreased the mortality by 50%, and it is really remarkable treatment. You know, I've read, for instance, that the number needed to treat to prevent one death is 8 patients in hypercapnic respiratory failure COPD. The number needed to treat to prevent intubation is 8 patients, 5 patients, I'm sorry. So this is very remarkable. But one thing that I'm always, you know, so patients with hypercapnic respiratory failure, they'll come a little tuned. And, you know, and there's this idea that you should not put a patient on non-invasive ventilation if the patient is too drowsy. But then, you know, non-invasive ventilation is likely to improve that. What strategy can someone take? And when do you think it's, you know, we should not put a patient on non-invasive ventilation? I've seen, for instance, in some places, physicians or respiratory therapists applying the mask to the patient for 15 minutes to allow the carbon dioxide go down so the patient wakes up a little bit. I think at University of Louisville Hospital have a policy: if the patient cannot reach out to remove the mask, you should not put the patient on non-invasive ventilation. What is your take on that?
I think that the thought is that if they come in hypercapnic respiratory failure and they do not have evidence of, they have obtundation, but no evidence of shock or other organ dysfunction, then I think it is and I've had this argument with respiratory therapists before, where you should give them a trial. Again, the trial should be fairly short and the patient should be monitored closely, but I tend to think that if the patient is able to reach up and remove the mask in the incidence of emesis or anything like that, I think that a short trial will definitely improve the chances of the patient not being intubated. Also, the evidence of overdistension with non-invasive ventilation, there's always the concern, especially from respiratory therapists, that you have gastric overdistension and risk for emesis, risk for aspiration, and things like that. In just kind of glancing over the literature, there did not seem to be a significant insufflation of the gastric with, you know, normal pressure support and PEEP in most cases. So I think that if the patient, so it's not as if using non-invasive ventilation is significantly increasing the risk of the patient having emesis and aspiration.
Well, that was really a wonderful review and so helpful on when we're dealing with these critically ill patients.
Yeah, we do
Jason, you
have
had one
we do have one question in the
Please.
chat, Dr. Moldoveanu, and it's from Dr. Emmons in hematology. He
Yes.
wants to know, how much is artificial intelligence influencing algorithms for respiratory failure? Is this technology making its way into ventilators and CPAP decisions?
So far, not a lot, but I think there are several measurements that are, it's so far still a clinical call by the clinician as to the cause of the respiratory failure and as to whether or not it makes sense. But I think that I think it's coming. There are a few composite scores to predict the failure of high flow nasal cannula, and NIV. However, those have not been yet quite validated. More to come very soon.
Okay. He did have an addition, an addendum. He says there are so many parameters that are manipulated and measured on a ventilator, as we are seeing for artificial intelligence evaluation of CXR. Are there additional parameters that the ventilator provides that can be applied to understanding of the broader condition of the patient?
Well, I think mostly the ones that we use kind of clinically is things like the respiratory rate, the inhaled tidal volume, and the airway pressures that however, the ventilator, to say yes, I think one of the uses for automated things would be a trending the changes in the usual things like the tidal volume and the respiratory rate and the and there has been so far quite a bit of proprietary research by the ventilator manufacturers in trying to deliver different modes of ventilation, patient assist ventilation, respiratory ventilation, where it measures the inspiration and it times the airflow with that. But there has not been a whole lot of study on if these alternative modes of ventilator and the self-regulating ventilators are any better than good old patient assist control non-invasive ventilation.
All right. I think that was the last question there. So I guess Dr. Williams, if you had anything to close with or any questions?
Just want to say thank you very much for a very insightful and so well organized, and we will go forward with that information and help our patients, but we'll still probably be doing a lot of pulmonary ICU consults when these issues occur. At this point, we're going to try to steal you for the Cardinal Minute, where you get to give a 1-minute summary. And I think, Jason, you might have had some closing words and something coming in the mail.
Yeah, well, actually, it'll be in your office, Dr. Moldoveanu. You'll receive for presenting Grand Rounds a gift, a commemorative Louisville Slugger bat of your very own. So I have it in my office. I'll leave it with Leanne tomorrow. So if you want to, you can get it from her. So we'll do that. So congratulations.
Thank you. Thank you very much.
Okay. All right. Thanks, everyone. So we'll all disappear, and then the three of us can come back. And Dr. Cavalazzi, you're certainly welcome to join us.
Yeah.
But not a requirement.
Yeah. All right. Thanks, everyone.